Good afternoon. The topic of my discussion is the use of erythropoetic-stimulating agents in acute illness. I'm specifically about to quote an article which talks about the use of erythropoietin-stimulating agent in patients with critical illness. I have no disclosure to make about any conflict of interest with the manufacturers, sellers, about any commercial or academic interest about a part or topic or drug discussed in this presentation. As a background, anemia and critical illness has been widely studied arena. The obvious causes of anemia and critical illness includes pre-existing chronic anemia or anemia acquired through things like hemodilution, blood loss, blood sampling, hemorrhage, decrease in the survival or production of red cell, abnormalities in iron metabolism, nutritional deficiencies, inappropriate erythropoietin production, or abnormalities in red cell production. If we look at healthy euvolemic patients, they have distribution of plasma volume and red cell volume that is at equilibrium, and with that the normal hemoglobin in a male is 13 grams per deciliter. In hemorrhagic shock, when you have likely loss of plasma volume as well as red cell volume, the average hemoglobin in the initial part is close to normal, but that is deceptive. In patients who are resuscitated with fluids, you can see a transient rise in plasma volume as compared to red cell volume. In those situations, even if the red cell volume is normal, you can see a low hemoglobin level just because of hemodilution. The various biochemical characteristics of anemia in critically ill patients includes low serum iron, low total iron binding capacity, high ferritin, low transferrin saturation. The erythropoietin concentration can be normal or slightly high. Now when I say high, it might still be inappropriately low for the degree of anemia. The various physiological changes that happens to RBC structure in critical illness includes decrease in the cell membrane sialic acid residues and glycophorin content, more spherical shape, and decreased cell deformability. The intracellular 2,3-DPG concentration can go up in alkalosis and it can go down in acidosis. As we all know, in various stages of erythropoiesis, erythropoietin is an essential growth factor. In critical illness, there are few factors that comes into action like interferon gamma, which inhibits the maturation of RBC as well as it induces apoptosis of premature RBCs. Tumor necrosis factor alpha, interleukins, and other cytokines may also inhibit maturation. The red cell transfusion has been associated with increased length of stay, does not offer mortality benefit, and at times carries risk for adverse events. Based on various observations and the trials about transfusion practices in critical care settings, the current concept is to use a higher threshold for red cell transfusion, and this came from as an inference from various studies done earlier. The one that I would like to quote is the TRICK trial that was published in NEJM in 1999. I came across this review article about the use of erythropoietin in intensive care unit, and this article particularly reflected the use of EPO beyond anemia. And what they tried to quote in this article is the use of non-pharmacological dose of erythropoietin in critically ill setting, which was studied in preclinical studies, and it has been found that it has tissue protective action against brain, heart, as well as kidney of several animal models. These non-pharmacological dose and these non-erythropoietic effects of EPO has not been studied in clinical settings to a larger extent. Several clinical studies have failed to demonstrate substantial benefits of EPO in critically ill subjects. The only benefit that we have observed so far is the reduced need for RBC transfusion. Again, the studies done earlier had smaller size and they failed to study other relevant clinical parameters. This is the particular study that I am going to talk about in this journal club presentation. This was published in September 2007 and it was done by authors from multi-centers, which includes New Hampshire, Vanderbilt, authors from Johnson & Johnson Pharmaceutical Research Arena, and so forth. It's a prospective randomized placebo-controlled trial. The study hypothesis was that therapy with recombinant human erythropoietin might affect the need for red cell exchange by reducing the need for red cell transfusion. The trial was conducted at 115 medical centers between December 2003 and June 2007. It was approved by IRB at various participating institutions. The principal author has disclosed that he is receiving consulting and lecture fees from Erythropoetic and Johnson & Johnson Pharmaceuticals. The patients that were selected for the study were the patients in medical, surgical, or combined medical surgical ICUs, and those patients who remained in the ICU for 2 days at least, and those patients were evaluated. Approximately 95,322 patients were assessed for eligibility. The inclusion criteria includes admission and ICU stay for at least 2 days, age 18 years or older, hemoglobin less than 12, and returned informed consent. The exclusion criteria includes expected discharge from the ICU within 48 hours after the second day in the ICU. Acute ischemic heart disease like myocardial infarction, unstable angina during ICU stay. A stay of more than 48 hours duration in the ICU of a transferring hospital. Presence of left ventricular assist device, history of pulmonary embolism, DVT, ischemic stroke, or other arterial or venous thrombotic events. Chronic hypercoagulable disorder. Dialysis for any indication. Uncontrolled hypertension with a systolic blood pressure more than 200 or diastolic blood pressure more than 110 millimeters of mercury after adequate antihypertension treatment. New onset seizure within past 3 months or that which is not controlled by medications. Third degree burn on more than 20% body surface area, pregnancy or lactation. Diagnosis of acute clinically significant GI bleeding on admission. Transfusion at the time of planned enrollment. Treatment with EPO in the last 30 days before enrollment. Inability or unwillingness to receive blood transfusion during the study period. Participation in other study, or hypersensitivity to EPO or any of its components. So a lot of the patients which we traditionally see in the critical care unit were excluded. The randomization was performed between 48 hours and 96 hours after admission to the ICU using computer generated numbers. And these are the various baseline characteristics that has been found in the study group as well as the placebo group, and we can see that the characteristics of patients were fairly matched as in regards to age, sex, Apache score, injury severity score, Glasgow Coma Scale, patients on mechanical ventilation, specific diagnosis on admission like post-operative trauma, neurological disease, cardiovascular disease, pneumonia, ARDS. Sepsis was found only in like 95 patients in the EPO group and 93 patients in the placebo group, which was somewhat surprising because a large number of patients getting admitted to ICU usually carries the diagnosis of sepsis. Again, the other medical characteristics and lab values were fairly even in both the groups. The study drug, which is branded as Procrit, was given at a dose of 40,000 units, or an identical appearing placebo was given. The study drug was administered on day 1, and after that it was administered on a weekly basis for a total of 3 doses. So the drug was given on day 1, 8, and day 15. The study drug was not given to patients whose hemoglobin concentration was more than or equal to 12 grams per deciliter at the time when the second or third dose would be given. This does not mean that the drug was withheld from the patients at day 1, and that was not something that was clarified. All the patients received iron either in liquid form enterally beginning on day 1 or whenever they could tolerate oral feeding. For patients whose T-sat was less than 20%, that means the transferrin saturation was less than 20% or the ferritin level was less than 100 nanograms per milliliter, were given IV iron. The need for red cell transfusion was determined by each patient's treating physician. The transfusion was targeted to maintain hemoglobin concentration between 7 to 9 grams per deciliter. Transfusion was not given if the hemoglobin concentration was 9 gram or more, or the hematocrit was 27% or more, unless they had active bleeding or ischemia. There was no predefined set hemoglobin level below 9 to determine the threshold for transfusion. This was left up to the physician's discretion. The study outcomes, the primary endpoint was defined as the percentage of patients receiving any red cell transfusion between days 1 and 29. The secondary endpoints were the number of red cell units which were transfused between days 1 and 42, mortality at days 29 and at day 140, change in hemoglobin concentration from baseline to whatever the number was at day 29. The number of patients that were needed for the study to have a statistical power of 80% to detect an absolute difference of 8% in the primary endpoint between the two groups was 1300. This is somewhat busy of a table, but we can see that around 95,000 patients were studied for eligibility, out of which, when they applied the exclusion criteria, finally 6,168 patients were eligible, out of which almost close to half were not approached for the consent and half did not give the consent. So ultimately what we were left was, what the authors were left was a group of 1460 patients which were fairly distributed in the two groups. The first outcome, that was the red cell transfusion, that is the primary outcome. The data collected was analyzed in two ways. The patients who had not yet received the study drug or were lost to follow-up during the study period were either considered not to have received the transfusion during study period, or they were analyzed in such a way that such patients were considered to have received the transfusion. This is very important to remember. There was no significant difference in the percentage of patients receiving red cell transfusion in the two groups. And this can be seen in the numbers here. The percentage of patients receiving transfusion in the EPO group was 46%, and then the placebo group was 48.3%. If we look at the relative risk, it was falling under the confidence interval of 0.85 to 1.06. So not too much of a statistical significance is observed here. In type B analysis, where they considered those patients who lost the follow-up or who did not receive the study drug and were considered to have received the blood transfusion, the patients in EPO group was 52.7% who received transfusion, and the patients in placebo group was 57.1% who received the transfusion. The relative risk is 0.92 and the 95% confidence interval is 0.84 to 1.01, which is again does not carry a heavy of a statistical significance. The transfusion rate, the number of units transfused for a given patient divided by the number of days the patient was alive, was expressed as a number in decimal point, which was considered the transfusion rate. And this is the summary of data on red cell transfusion as published in the journal itself. And we can see that the number of patients receiving transfusion in the EPO group as well as the placebo group was not significantly different, and that calculation was even not statistically too much of a heavy difference. The transfusion rate remained fairly even in both the groups and fairly equal in both the groups. The transfusion practice that was observed in this current study group was that the mean pre-transfusion hemoglobin concentration was around 8.2 in the EPO group, and in placebo group it was 8.0. This reflects the current concept of highering the threshold for RBC transfusion in the critical care setting. The percent of patients receiving transfusion to maintain a hemoglobin concentration between 7 to 9 was also much similar in the two groups. It was 74.8% in the EPO group and 77.2% in the placebo group. The transfusion for acute bleeding was also fairly even in both the groups, and the transfusion before randomization, that is before the study drug was given, was close to 57.8% in the EPO group and 54.6% in the placebo group. At day 29, the increase in hemoglobin concentration from baseline, which is again a secondary endpoint, was almost equal in the two groups, and the absolute hemoglobin concentration was 11.2 plus or minus 1.8 gram per deciliter in the EPO group, and it was 10.8 plus or minus 1.7 grams per deciliter in the placebo group. By day 42, the hemoglobin concentrations in the two study groups were not significantly different, and this was one more secondary endpoint. This was interesting, the mortality data. At day 29, they were able to demonstrate that there were less number of deaths in the EPO group as compared to placebo group, with a p-value of 0.02 calculated on a t-test, which implies statistical significance. The overall mortality data was expressed in this table, and it says that at day 29, the percent of mortality in the EPO group in all the patients in general was 8.5% as compared to 11.4% in the placebo group. Again, the hazard ratio was adjusted as well as unadjusted. When they say adjusted, the adjusted hazard ratio is from a Cox regression with a study group, age, sex, admission group, acute physiology and chronic health evaluation, that is the Apache score, baseline hemoglobin, iron and serum creatinine concentrations, types of coexisting conditions, and injury severity score for trauma patients as covariates, and all these covariates were adjusted. If we look at more closely, we can see that the hazards ratio was falling in the confidence interval of 0.53 to 1.02 in the unadjusted analysis, and in the adjusted analysis it was falling in 0.56 to 1.10. This is not statistically significant. The highlight of this study was that they were able to demonstrate a reduced mortality in the trauma group, and again the hazards ratio was falling in a statistically significant way. This was at day 29. At day 140, the trauma patients had lesser mortality in the EPO group as compared to placebo group, but this one did not carry statistical significance because the hazard ratio again was falling in a confidence interval of 0.38 to 1.06, and when it was adjusted for all those covariates, it was falling in a statistically significant range. So again, too many confounding factors, but in all fair sense, they were still able to demonstrate some mortality benefits in the trauma group per se. The adverse events, at least one adverse event was noted in 94.8% of patients in the EPO group and 94.4% of patients in the placebo group. And I'm going to talk about this as to why such high incidence of adverse events happen in these patients. Just remember that these patients are critically ill patients. The serious adverse events was 44% in the EPO group and 43.5% in the placebo group, which was equal in both the groups, almost equal. When we talk about the serious adverse events, the events includes any respiratory system disorder that includes respiratory insufficiency or shortness of breath, or sepsis or abscess was almost equal in the two groups. The only clinically relevant things that came out of this study was that the incidence of things like pulmonary embolism, DVT, cerebrovascular accident, MI, or cardiac arrest or ventricular fibrillation was slightly on the higher side on the EPO group. Out of all these, the incidence of deep venous thrombosis was higher in the EPO group as compared to placebo group with a statistical significance p-value of 0.04. The incidence of myocardial infarction was also higher in the EPO group as compared to placebo group with a p-value of 0.08, which is again statistically significant. When they analyzed those patients and stratified them into those patients who received heparin at baseline and those patients who were not able to receive heparin at baseline, they found that in spite of adjusting those variables, the mortality rate, the rate of thrombotic events in the EPO group was higher than in the placebo group. Again, the hazards ratio was not falling into a statistically significant range except on those patients who were not treated with heparin at baseline. All in all, the fair inference from this study is that the incidence of thrombotic events, particularly the deep venous thrombosis and MI, was statistically significantly higher in the EPO group. The study drug did not affect the length of stay, and the length of stay stayed fairly equal in both the groups. The length of stay means median length of stay in the ICU as well as median length of stay in the hospital. The use of mechanical ventilation also did not differ in the two groups, and they expressed the use of mechanical ventilation in three different categories: median duration of ventilation, number of ventilator-free days, and discontinuation of mechanical ventilation as observed on day 140. And we can all see that the numbers remain fairly equal in the two groups. The conclusion that was offered by the study is the use of EPO or Epoetin alpha does not reduce the incidence of red cell transfusion among critically ill patients, but it may reduce mortality in patients with trauma. Treatment with EPO is associated with an increased incidence of thrombotic events. Now, this was the final conclusion offered by the study. So if someone has to just look at the abstract and the conclusion drawn here, they might get tantalizing results or tantalizing idea about transfusion practices as well as use of EPO in trauma patients. The good thing about the study is the transparent reporting of the recruitment and retention of patients in this trial. The rate of adverse event reflect that critically ill patients undergo a series of acquired and established evolving static or resolving complications, so they are bound to have higher rate of adverse events. Sometimes such comprehensive reporting of adverse event might induce false or inappropriate alarm about safety of the drug. But this is the good thing about the study, that they were very transparent in reporting all the events that happened. Although the patients with prior history of thrombotic events or CKD or cardiac ischemia were excluded, the rate of thrombotic events was higher in the EPO group. It was not clarified in the study as to how the diagnosis of DVT or PE was made, whether the patients were tested on clinical suspicion or whether all the patients were tested. And in the previous studies, it has been shown that physical examination is an insensitive way to identify proximal DVT or pulmonary embolisms, especially in patients who are in semi-recumbent positions on mechanical ventilation in the critical care setting. The remarks includes that the concept that EPO saves the life of trauma patients with hemoglobin below 12 or who are in the ICU for at least 48 hours and who do not have renal insufficiency or prior venous thromboembolism is very tantalizing, but I think it's premature. And I will again come back to the mortality table here, and I would like to stress the fact that at day 29 and day 140 there was lower incidence of mortality in the EPO group, but it was not statistically significant in all the instances. After statistical adjustments, there were few more survivors in the EPO group in trauma category, which is not sufficient enough to provide support for routine use of EPO in practice in such patient population. I also came across meta-analysis of various studies done on the use of EPO in critically ill patients, and I pulled out 3 selected studies which had higher strength because of the higher number of patients, and all I could say is that the number of patients enrolled in each study was 160 or 1300 or 148, and 2 such prior studies were done by the same author who did this current study. The dose of EPO was also fairly similar. I would just go straight to the inference of this study. When it comes to aid reducing the number of transfusion, all the studies favored EPO. When it comes to offer mortality benefit, the study done by the same author in 1999 did not show any mortality benefit. Again, the study that was done by the same author in 2002 and published in JAMA showed some mortality benefit, and I haven't gone into the details of that study to be making a generalized statement about anything. And the study done in 2005 by a different author, done on 148 patients, was quite neutral about mortality benefit. So the final message that I would like to share with all of you is this, that at this time the routine use of erythropoetic-stimulating agents in critically ill patients cannot be justified based on available evidence of minimal benefits in terms of RBC transfusion, and there is insufficient evidence about appropriate dose that is less risky in terms of thromboembolic and other not studied complications. The concept of using non-pharmacological dose of EPO for tissue protection beyond erythropoiesis has been studied in preclinical trials, but in clinical trials we haven't obtained an encouraging evidence yet. Thank you.